So in your patients in long-term care facilities, you may be seeing kind of more of that stage of Huntington's disease. And we'll talk more about those movements in a bit. So how do Huntington's patients differ demographically from average nursing home residents? Well, sometimes they can be younger than your average patient in a nursing home, although both males and females get Huntington's disease, and sometimes they have some of these more severe movements, and they get psychiatric and behavior disorders are common, things like depression, stress, anxiety, this type of stuff. So when you get into things like later stages of Huntington's disease, then one of the big things, well, there's two big things that really kind of dominate it. One, because all of your movements are small and slow, and that includes the movements of swallowing in the throat and things like this. And so you get into choking on foods and liquids, and you're trying to prevent things like aspiration pneumonias. The other big part about this is because all the movements are small and slow, and then you get an internal sense of loss of balance. So you get falls. And so with your kind of later stage Huntington's patients and patients that end up in things like long-term care facilities, the big things you're trying to do is I'm trying to prevent falling down and breaking arms and breaking legs, and then I'm trying to prevent choking on foods and liquids, because those are really the classic ways that people die. So, the classic of fall down, break arms, break legs, and then I have to go have surgery to fix my knee or my leg or something. And then I'm laying in a hospital bed for 6 weeks, and then I get aspiration pneumonias, blood clots, bladder infections, stuff like that. And those are the classic ways that people die. The other one would be choking on foods and liquids, and then I get aspiration pneumonias, and people can die from that. They get septic and that type of stuff. So then the way you deal with that is you try to prevent that scenario from happening in the first place. So assessing disease progression in late-stage Huntington's patients, there's really 5 big parts that we're talking about. So mobility, being able to prevent falling down, breaking arms, breaking legs. At what point in time do we go to wheelchair bound? At what point in time do we go to bed bound even? And then feeding, so trying to prevent choking on foods and liquids, from eating independently to thickened liquids to things like feeding tube in really advanced cases. Things like continence and self-hygiene. So they can lose some frontal lobe components. So they don't focus on things like self-hygiene without people reminding them to do that or helping them to do that. And then communication, they can go from just communicating like you and me to really limited ability to communicate. And then participation, so interactive in all activities, or are they not interactive? And some of that participation could be secondary to, it's hard for me to do the task, to get up and go do the group activity. And then some of it can be, well, there's a lot of things like depression associated with Huntington's disease. And maybe it's that I have a lot of depression and you know what, I just don't want to do it. I'm just going to stay in my room and not participate. And recognizing that, hey, that can happen. And of course, there's a lot of different medicines that can be helpful in the setting of depression too. Okay, symptoms of late Huntington's. So we're talking about some of these motor movements, and then some of the psych movements, and then some of the cognitive problems that people get too. So with some of the motor symptoms of Huntington's disease, we typically think in terms of chorea. We typically think in terms of chorea. So this is an involuntary movement flowing in X, Y, and Z planes of axis from one joint to the next, although sometimes it can be a little bit slower. Sometimes it can be really big. I'm just all over the place. And this isn't just limited to my hand, but it can be everywhere that I got. They can also get things like dystonias. So dystonias are a sustained involuntary muscle contraction. So an example of a dystonia, well, everybody gets a little bit of dystonia every day, and that's normal. So let's learn about what that is, right? So dystonia would be, if you ever had that little twitch in the corner of your eye, and like when you get like really stressed out, frustrated, lack of sleep, too much caffeine, anxious, morning after alcohol, these types of things would be the classic ones where you get the little twitch. That would be a version of dystonia. And that type of thing is normal. Everybody gets that. So it's okay. I get it too. Or sometimes I'll get it in one of my little face muscles right here. Or for whatever reason, man, I don't get it. I don't understand. But I get like mild dystonias like that, like the little twitch in the corner of your eye. I get it in my right lower leg for some reason. I don't know, dude. Like, that's how it's been since I was a kid. That's how Jesus made me, right? So there's a little bit of these things are normal, but when you get to these types of dystonias in Huntington's disease, they can be a real problem. So the arm is involuntarily contracted all the way over, something like this, or the neck is back, or these types of things. And then, interestingly, so things like chorea and dystonias, these are hyperkinetic movement disorders, too much movement. But they also get too little movement, and we classically associate things like too little movement with Parkinsonism. So like Parkinson's disease. So they don't get tremor, like everybody thinks of Parkinson's disease as having this type of tremor. They're not going to get the tremor, but they will get things like bradykinesia. So let's define what that is. I ought to be able to take my hand and make this big, fast movement like this, where the size of the movement is staying the same every time that I do it. But in bradykinesia, and you'll see this in your Huntington's patients, it'll be that either the whole thing is too slow, or that I'm going and I'm doing okay, but here I'm going to move it. I'm going and I'm doing okay, but as I keep going, it gets smaller and smaller, and so I can't make the big movements that I want to make. Or that I'm going and I'm doing okay, and then it gets like stuck, and then it starts going again. Like all three of those things are bradykinesia. You'll see those in your Huntington's patients, and you can see why, if that's happening, it's not just in my hands, it's everywhere I got. And so if that's happening in my feet and my legs while I'm trying to walk, that I can start getting off balance because of that too. And then they'll get rigidity. So all the muscles are stiff and rigid, and it's not just in the hand, but it's everywhere you got, in your trunk, in your hands, in your legs, everywhere. So it becomes a problem for them trying to perform activities of daily living. Hygiene stuff, brushing of teeth, getting dressed, cufflinks, buttons, stuff like that, hair, makeup. All these types of things can be more difficult. And as they're progressing in late stages of Huntington's disease, like we said, this starts out as both a too much movement and a too little movement problem. But as it progresses over time, it becomes just a too little movement problem. So they don't have as much chorea anymore, but they have these small, slow movements, muscle stiffness, rigidity, getting off balance, postural instability, falls, choking on foods and liquids. And those are the things that really define these kind of later stages from a movement disorder standpoint. And remember, we're trying to prevent falling down, breaking arms, breaking legs, and choking on foods and liquids. Oops. So with these extra movements like chorea, there's some medicines that we can do to help with this. For choreas, kind of an older medicine would be something like tetrabenazine. A newer medicine with a FDA indication for Huntington's chorea is deuterated tetrabenazine, which is Austedo. It came out maybe 5 years ago or so. That has the FDA indication and is typically not a problem to get through insurance companies. And what I'm trying to achieve with Austedo, with deuterated tetrabenazine, is improvement in choreas, all these extra movements that I'm getting with my hand. It's not going to be helpful with the small, slow movements that we were talking about. It's not going to be helpful with getting off balance and falling down from an internal sense of loss of balance standpoint. It's not going to be helpful in choking on foods and liquids. If you're getting off balance and falling down because I've got chorea everywhere and it's knocking me off my balance, and then I can't correct fast enough, it might be able to help with that some, but that would be fall secondary to chorea. Remember, what you're trying to do with Austedo is chorea, is all these extra flowing movements, like dance-like movements. That's what everybody talks about. I'm not going to stand up and dance for you today. It's a Monday morning. I don't have it in me. But imagine if I were to just, really cut it out there, it would look like that. Because clearly I'm an excellent dancer, which is why I'm not proving it to you right now. Okay. VMAT2 inhibitors, long-term care facilities. So these things can get dispensed directly to long-term care facilities in blister packs, or however you guys like to get it. Every long-term care facility's pharmacy is a little bit different. That's fine. Like, we can work with that, right? Some of the older medicines you can use for all these extra movements like chorea would be the antipsychotics, although there's pluses and minuses with using these types of things. So the classic ones, the older ones like Haldol, Mellaril, Pimzide, ORAP, Thorazine, those types of things, they can be helpful with all the extra movements, but they can cause a lot of other problems too. And then the atypical antipsychotics, these are the newer ones that get used more often nowadays. These came out in the 1990s. So things like Risperdal, Zyprexa, Seroquel, those types of medicines. kind of the pluses versus minuses here of the older ones, which would be typicals on the left side of the screen, and the newer ones, although they're 30 years old now, the atypicals on the right side of the screen. The atypicals can cause maybe a little bit more sedation, particularly with Seroquel. Seroquel makes people sleepy. But with all the other things, people tend to tolerate them a lot better. So things like dry mouth with systemic hypertension, drug-induced Parkinsonism, stuff like this is much better with the newer medicines. So typically, if you can get away with using the newer medicines, then this is probably a better choice. Overall, but every individual patient is different. And then with Huntington's disease, what's really interesting is because remember we said this was genetic. And so most people with Huntington's disease, well, they remember when mom or dad had this. And so sometimes you'll have patients that say, you know what, absolutely, I am not going to take that Risperdal because I remember my mom took Risperdal and then she died 2 years later. And I think that was from the Risperdal, not from the Huntington's disease. When in reality, and Huntington's disease is going to continue to progress over 15 years or so. People were trying most likely the Risperdal was trying to be used for things like chorea or even hallucinations and stuff like that. But in the patient's mind, they associate bad outcomes with some of these medicines. And so sometimes patients can be really reluctant to start medicines for Huntington's disease because of that, because they remember the names. One of the most important things we do in medicine is get patient buy-in to the game plan. And so whenever I'm talking about starting a new medicine in Huntington's disease or Parkinson's or other stuff, I want you to buy into the process. So I'm going to explain, hey, this is the medicine, this is the movements that I'm trying to make better, this is what it can help, this is what it cannot help. What do you think about starting it? Because I want you to say, yeah, I want to start this drug, because then you bought into the process, you're going to be more likely to be compliant with it and happy with it and all that type of stuff. So patient buy into the game plan, always a good idea. Non-medical stuff for chorea. Physical therapy, speech therapy can make wonders happen. Things like wheelchairs, padded seats, padded bed rails. Remember, because these are involuntary movements and they're happening as you're trying to lay in bed and go to sleep. And if you're whacking your arm and your leg or something on the bed rails, hey, that hurts. People get bruised. So padded bed rails can be really helpful. Limb restraints aren't fun. Pretty hard to go to sleep with being tied down on your wrists and your ankles and stuff. So avoid those if possible, especially because of all these hyperkinetic movements. Things like rolling walkers can be incredibly helpful. This is a really great example of a good one. So there's a place to sit down there. There's a backrest there. They've got the little handbrakes on there so that it doesn't slide away from you. These sorts of things are a lot better than just like the classic 4-prong, walker that doesn't have wheels or anything like that. That can be a little bit difficult to use. So other involuntary movements with dystonias, if they're really bad and a problem, we can use things like botulinum toxins, so things like Botox. Although Botox is really simple in what it does, it just weakens muscles. That's it. It's going to weaken muscles for about 3 months, and then it wears off, and you repeat the injection. So you're always asking yourself, if I weaken that muscle, am I going to make things better, or am I going to make things worse? Because if I start weakening muscles in your legs, well, I can quickly make things worse by making you more likely to fall down. So just be aware of those sorts of things. And then if we're getting into it, as the Huntington's patient is progressing over time, we said that they start out as hyper and hypokinetic, too much and too little movement, but then they progress over time to just too little movement. So a lot of times as they progress in their disease state, they need less things like tetrabenazine or the antipsychotics because we're not trying to control the chorea as much. Choking on foods and liquids becomes a huge problem here. Things like trying to prevent aspiration pneumonias, weight loss. Things that can be helpful here would be thickened liquids, physical therapy, speech therapy. It can be really frustrating for the patients because it's difficult for them to get the words out. And you imagine, going through life and not being able to communicate in the way that you want to be able to communicate. Can be an incredibly frustrating thing. Imagine you or I trying to go through life and interact with family and stuff like that, being completely nonverbal. That's pretty tough to go do. So we have things like these communication boards, which these are pretty cool. And so you can kind of pop through here and point to the things that you want or click on the things that you want, and can make it a lot easier to communicate with folks around. Things that could be helpful with drooling. If it's really bad, actually, botulinum toxin, Botox injections into the saliva glands can be really helpful with drooling. There's some other options too. Sometimes medicines can be helpful, particularly in younger patients. Using straws, using thickened liquids, doing things like speech therapy can be really helpful. From a weight loss standpoint, trying to do things like increasing calories. I tell my patients, I don't know, what's your favorite? Is your favorite ice cream? Is your favorite mashed potatoes? I don't know, go eat that. Go have fun, knock yourself out. Try to get those calories in you as best you can. So from an activities of daily living standpoint, so things like bedside commodes, shower chairs can be really helpful. If you're trying to turn in the shower, then you're pretty likely to fall down in that scenario. If you're still living at home, or maybe they have little kitchenettes or something in their rooms, I don't know. Like in the kitchen, typically you're kind of like turning and, I've got to grab the pan and then over here for the thing. And as you're just turning there in the kitchen, that's when a classic time when people fall down there too. Let's talk about the cognitive. Huntington's disease dementia is a common problem, and it can be a problem enough to get in the way of daily functions. It's a little bit different than things like Alzheimer's disease, and they can continue to understand words and things like that. They can have just a global slower processing, disorientation to time, and we talk about some of the communication problems they get into also. So treating cognitive symptoms in Huntington's disease, pills probably aren't going to be very helpful with this. We have things like, Aricept, Donepezil, stuff like that, Namenda, Memantine. Those are drugs for Alzheimer's disease dementia, but the reality is they're nowhere near as good as what we really want them to be. And even in Alzheimer's disease, they can be like kind of helpful in early stage Alzheimer's with stuff. But outside of those medicines, you really don't have choices in Huntington's disease. And like these medicines are not the game changers that we want them to be. So then planning ahead for things like dementia can be really helpful with family members and stuff like that. How the family or how the patient would like to be cared for, advanced directives, those sorts of things are really critical here. So from a communication standpoint, kind of getting to know your patient, knowing the likes, the dislikes, the body language cues, teach everybody who'd be caring for the patient that, these patients, you can get away with a whole lot of nonverbal communication and still understand what's happening. Like if you experience this and go travel, I am not a bilingual person. So if I go do international travel or something, I'm going to be a little bit confused and maybe I can't figure out quite what's happening here. But for the most part, you can kind of work your way through this or pantomime your way through conversations or, things like, hey, thank you, that type of stuff. Stimulants, things like Ritalin, Adderall, sometimes they can be helpful in apathy withdrawal, but stimulants like this will commonly cause things like confusion, hallucinations in dementia patients or in older patients. So there's always, like everything else in medicine, there's always what do you gain versus what do you lose. So just be aware with those sorts of medicines. Particularly if you're getting into dementia and hallucinations, I would probably get rid of them. And then depression plays a huge role in huge role in Huntington's disease. These patients have seen what mom or dad went to, and they understand what they're in for. They know what the disease state progression is going to be. And a lot of times they carry this underlying depression, stress, anxiety with them through their entire lives, since they were teenagers or something and kind of first understood what Huntington's disease can be. And so it can play a massive role. Lean on our friends in psychiatry. They can be incredibly helpful with these patients. Other things that can be helpful, maintaining sleep-wake cycle. Trying to keep bedtime about the same time every day, trying to keep waking up time about the same time every day can actually be incredibly helpful in these patients. And then trying to keep naps limited somewhat. So, if I come home from work and I take a 3-hour nap, then I feel really great after that nap, but I'm probably not going to sleep very good later that night, right? because I got too much sleep when I got home from work. So you're trying to kind of regulate that sort of thing. And it can be tough too in places like long-term care facilities or even at home before they get there. Well, I'm retired. I just stay at home and I sit on the lazy boy and I watch reruns on the History Channel all day long, and I kind of sleep in the afternoon and all that type of stuff. So trying to keep things active so that they're regulating their sleep-wake cycle. Let's talk about some of the behavioral stuff. So like we said, depression, anxiety are really common in Huntington's disease. And because you're getting some kind of frontal release type things, you can get into things like paranoia or being suspicious, obsessiveness, irritability, explosiveness. Although, I think different people take out their underlying depression in different ways. And one of the classic ways that, and I get to say it because I'm one of these guys, right? One of the classic ways that, well, first off, good advice in life: never underestimate the stubbornness of the adult male. Okay. I feel like that's just a good kind of baseline thing there, which I'm guilty of. I do it too. But a lot of times you'll see these big, strong guys, big, strong males that say, well, no, I'm not depressed. But I just get really angry, like at just the flip of a switch, and I get really angry and frustrated and stuff like that. And a lot of times that can be some underlying depression that's happening there, but I don't feel comfortable as a big, strong man saying, hey, I have depression. It's easier for me to just be angry, So that's something to be aware of. And when I'm asking about depression, I'll ask the patient and then get their answer. And then I'm going to turn and ask the spouse or the family member and get their answer, because a lot of times it's a little bit different, right? Of course, with things like depression, there's a lot of pills that can be helpful with depression. And typically these medicines are really well tolerated. In getting that patient buy-in into taking medicines for depression can be really helpful. Although, these things aren't like happy pills. You don't take them and all of a sudden you feel better. They take a month and a half to get into the system and start working. So setting reasonable patient expectations for medicines can be really helpful too. If you get into problems with impulsivity, that's a discussion to have with psychiatrists, and maybe starting things like mood stabilizers, whether that be Depakote or Risperdal or other choices there. With screaming out, this can be very end stages of disease, especially in mute patients. Although, keep in mind, hey, maybe they're screaming because they really hurt themselves. They whack their arm on the side of the bed or something like that, and it's really uncomfortable. So make sure we're checking for those types of things too. And then other issues, we talked about aspiration pneumonias, abandonment, and a lot of times family members, they tend to isolate themselves from family members for various reasons. And so, and also it's really emotionally challenging too if I know that I have Huntington's disease and mom has Huntington's and mom's in a long-term care facility, and then if I go visit mom, then I have to see what I'm in for. And that's incredibly challenging. I mean, geez, imagine putting yourself in that scenario, right? And so a lot of times these patients can feel abandoned because they don't get visited by their family members. We talked about weight loss. Any patient that's bedbound, wheelchair-bound, you're worried about things like blood clots. So keep that in your mind. And then from a safety autonomy standpoint, a lot of times it's better to discuss this stuff ahead of time. What are we going to do with aspiration pneumonias and difficulty swallowing foods and liquids really becomes a problem? What happens when we refuse PEG tubes? Is PEG tubes a good idea? All of these end of life questions need to be talked about, preferably like well beforehand when everybody can talk about it. Some fantastic resources through the HDSA. There's the website there, but you can just type in Huntington's Disease Society of America, and they're really easy to access. And they have these great handouts. You can print them out and give them to patients, give them to family members, or just have them available for when the scenario hits. But HDSA is a fantastic organization, and I'm very happy that I get to work with them on a regular basis. And really, that's all the slides. These are the UAB Huntington's disease guys that I'm very proud to get a chance to work with. These are absolutely wonderful people. It's very humbling to get to work with people that are so fantastic at what they do on a regular basis in a disease state and patients that that can use all the help that they can get. So I'm very proud of that, to be associated with it. But that's kind of what I have here. Any thoughts or questions or anything like that?
I have some questions, and I'm sure others do as well. But my first question is, what led you? What is your interest? What led you to this Huntington's disease?
So I'm a movement disorder expert. So what that means is I did my 4 years of undergraduate. I'm a neurologist, so 4 years of neurology residency, and then I did additional training in movement disorders. I did my additional training in movement disorders because I thought it was fascinating. There was a huge need for it. I always kind of look through the viewpoint of what I'm trying to achieve in my career is I want to achieve the greatest positive impact in the area that I serve and the time that I have. And for me, doing the Movement Disorders Fellowship really allowed me to get a niche role within the area to make much more of a difference than I could if I was a general neurologist and out in the community. And that was just me. I mean, I got a lot of respect for those guys too, because it's really tough. And then by doing this, I get the opportunity to do educational things. And I'm the 3rd and 4th year medical student clerkship director at University of South Alabama, and work with the neurology residents and train the doctors how to be doctors and that type of stuff, which is incredibly humbling and absolutely fantastic. And then within movement disorders, Huntington's disease is one of our major diseases. So, that there's so many improvements that can be made in the Huntington's patient, and so many different treatment options that we have now that we didn't even have, 10 years ago or 15 years ago or something like that. It's an amazing disease space to be working within.
And so if I were a 30-something-year-old coming into your office to learn that I have this disease, I mean, it's 100% likely that one of my parents or grandparents or someone has it. Is that correct?
Well, it's pretty likely. You're always careful with things like 100%. But, classically you think in terms of this is an autosomal dominant disease that gets inherited from either mom or dad. And the reason I say always be careful with 100% is because, geez, I don't know, somebody on this earth had to be the first guy to get this thing, right? And so, you can get these sort of spontaneous mutations too, but that's pretty rare. Although, there's genetic tests. We haven't talked a lot about genetic testing, but there's genetic testing that can be available to help diagnose things like Huntington's disease, or genetic testing that can be available for people that, mom or dad has Huntington's disease, and I want to do the genetic testing because I want to know, am I going to get Huntington's disease? Do I have Huntington's disease also? Although there's a lot of education that goes into genetic testing because it doesn't just affect you as the patient, it affects the whole family, and it'll affect your kids and stuff like that. So that needs to be a big family discussion, and using things like genetic counseling and talking with a neurologist and stuff like that can be incredibly important.
And so again, if I'm a 30-year-old coming in and I'm finding out that I have this diagnosis, what is the progression I can expect? At what point should I realize I may have dementia?
So classically, Huntington's disease plays out over maybe 15 years, although everybody's different. Some people's progression is way slower than that. What I would typically say is look at what the progression was with mom or dad. And then in a lot of ways, you'll have a similar type of progression, particularly if it's mom, I have a similar type of progression. With dad, there can be a little bit of variability there. Just to kind of, see how these things will progress over time. Luckily, you don't get into things like cognitive problems typically until later on, really severe cognitive problems until later on. But things like depression, anxiety, stress, all that type of stuff, I mean, patients will have this for a lifetime. Potentially, is some of that from just Huntington's disease in and of itself? Sure. Is some of that from the sociologic aspect of going through life, knowing that mom has Huntington's disease and that I have a 50% chance of having this thing, and I got to see how mom's whole life played out? I mean, that's going to play a huge role in somebody. It can't not play a huge role in somebody. So and that's where I think things like patient education become so critical, because the thing you fear the most is whatever is behind the door that you don't know what it is, right? Whatever is behind the closet door, that's the biggest, scariest monster when you're 6 years old. So then the best way to approach that is, well, let's learn about it, right? And by learning about it, we can educate, and we lose the fear, and we learn knowledge.
And so then you would fall down on the side of doing the genetic test to discover if you have this.
Well, that's a very personal choice. And, my opinion on that is very different than what other people's opinions on it. But, I work in medicine. I'm super type A, OCD, ADD. Like, you got to have those for the most part, you got to have those personality traits to do things like get through medical school. The fact that you got to do your homework every time, is helpful in school and stuff like that. So that's a different personality trait than what a lot of people have. And that's okay. The way I approach that is with genetic testing. I want to explain how all this works. I want you to understand how the genetics of it, the inheritance of it, what the gene test means. I want all the family to talk about it and understand it. And then we can have a discussion as to whether you feel like this is right for you or not.
It's clear to me that you are addressing the whole person, psychologically, cognitively, physically. It seems to me that your work is very important, and it would be very stressful in and of itself.
Well, it's important to me. These things are important in life, and there's a lot of different types of jobs out there in the world, and I feel confident that what I'm doing on this earth is what Jesus wants me to go do. Then hell yeah, let's go do it, right? Like, that's enough internal motivation for me. But everybody's different, right? So go find what you're supposed to go do in life and attack it as voraciously as you can, right?
That's right. We have a question in the chat room. Missy Etheridge said, and she apologizes for missing this, but and she understands that progression from the person with the disease is very much like their parents. But she asked, what is the age range of onset for symptoms?
So classic age range of onset is going to be in your 30s, 40s, 50s. Although everybody's different, and it depends on the number of CAG repeats that you get. The more CAG repeats that you get, the earlier onset you're going to have. And we say that kind of cutoff is typically, we say things like 36 CAG repeats. If you have more than 36 CAG repeats, then you're probably going to get Huntington's disease. Although the more that you have, the earlier onset. So if you have something like 37 CAG repeats, you may not have this until like way later in life, 70s, 80s. If you have some giant number like 60 CAG repeats, you'll have this onset as a child, which is really devastating with onset as a child. So typically what you look for is how old was mom when she had onset of disease state. That can be helpful. With dad, there's a little bit more variability there, but it can give you kind of a rough guideline as to how things go. So absolutely you can have onset in your 20s or teenage years, but luckily that's a little bit more rare. That's a great question.
And I have a comment from a Ms. Brantley. Darlene Brantley says she had a hospice patient diagnosed initially with Parkinson's. Of his 5 siblings, all male, all but one was diagnosed with Parkinson's or Huntington's. The other brother didn't want to be assessed. My patient was in his late 30s, eventually was tested and had the Huntington's gene. He became suicidal. It's all very sad.
So with movement disorders like Huntington's disease and stuff like that, I think seeing a movement disorder expert at least just once for making that diagnosis can be incredibly helpful. Because like we said, with Huntington's disease, you get all these extra movements, these flowing movements, too much movement, but you also get too little movement too. And there's some overlap with the too little movement that you would typically see in Parkinson's disease. And so I could see how teasing out that diagnosis between is this Huntington's or is this Parkinson's disease can be a problem. So, rely on your movement disorder experts. The guys at UAB are fantastic. Or if you're in the southern half of the state, come see us at South Alabama or wherever you're at. That's a resource that should be used. And, it points out with things like suicidal and Huntington's disease, that's actually a major issue because they have terrible depression and anxiety. And they, like we said, they see what happened to mom or dad. So then let's educate, learn about it, talk about it, manage things like depression and suicidality. You know, the worst thing you can do with suicidality is just ignore it. You know, this is an important thing to feel comfortable talking about with your patients, talking about with patients' family members and stuff like that. The patient should be comfortable talking. You know, you're trying to get your patient comfortable talking with the patient's family members, friends, whoever, you know, whoever's in their sociologic realm. Because a lot of times patients will just ignore this thing, or we ignore it because we feel like it's taboo, and it's not. Like, we're all humans, we're all in this together, right? Like, if this is what's going on, then let's talk about it.
Well, thank you so much. Yeah. I haven't had any other questions arise, and you may know it's 12:58. Our folks need to get back. I know I join everyone on the call in thanking you for not only this presentation, but for the work you do. There are those of you that may still need the password link. I will give it once more. It's https://www.surveymonkey.com/lowercase r/ Q8H697T as in Tom. And our password is HDCE USA, all caps, and that stands for Huntington's Disease Center of Excellence at USA. HDCE USA is the password. Thank you all for being here today. This is a terrific topic, Dr. Dees. If you're open, we'd love to have you back anytime. It's a standing offer, and it's been most fascinating. And that's the comments rolling through are exactly that. This has been fascinating. I thank you so much. Thank all of you for joining us and for choosing CarePatrol for your educational needs. Have a great week.